Okay, welcome back, guys. This time we shall be talking about first heart sound, which is much more simpler and easier to comprehend. First heart sound is characterized by mitral and tricuspid valve closure, and most of the questions on the topic will revolve around the intensity. The concept to be remembered or the logic to be used by you is based on the fact that intensity is directly related to the speed of closure. So if I have a loud S1, that implies that the valves are moving with much more faster speed, and therefore one of the easier outputs for you to remember is that loud S1 will be found in patients with tachycardia. Now when I say the word tachycardia, how's the examiner going to write the word tachycardia? He's going to exploit one of the laws of ECG, that PR interval is inversely related to heart rate. So in a lot of questions, you will notice that the question will begin by saying patient is having short PR interval. What will happen to the intensity of first heart sound? Your answer is that short PR interval implies tachycardia, and therefore there's a loud S1 in the patient. Or instead of saying tachycardia, he could write conditions having tachycardia like congestive heart failure, or causes of congestive heart failure like severe anemia or beriberi. Or he could write endocrinological conditions where there is presence of excess of catecholamines like pheochromocytoma, thyrotoxicosis. So when it comes to the examiner, tachycardia could be any of the following conditions that I have written on the board before you. Or he could be writing conditions causing congestive heart failure like beriberi or severe anemia. The second concept to be remembered for loud S1 is that loud S1 can be physiological. I mean, you don't press on the panic button if S1 is heard in children, because children anyway have a faster heart rate than us. Or you don't press on the panic button with respect to loud S1 in pregnancy, because in pregnancy obviously there's a faster circulation, there's a hyperdynamic circulation. Loud S1 is also a feature in patients of mitral stenosis and tricuspid stenosis. Let us understand why. In patient having mitral stenosis, because there's a physical obstruction, the left atrial pressure will become higher than yours and mine. Because left atrial pressure will be higher, the higher pressure will be responsible for faster opening of the mitral valve. Because there's a faster opening of the mitral valve of the patient, there will also be a faster elastic recoil, and this faster elastic recoil will explain the loud S1 which is present in the patient. In a textbook, this is simply written as enhanced transvalvular gradient. But what I mean by the word enhanced transvalvular gradient is much more simpler, that there is a faster opening and a faster elastic recoil which is responsible for development of a loud S1. Now let me say hypothetically that there is a calcium deposition in the valve. If a patient is having calcified mitral stenosis, then I think you would all agree that due to calcium deposition in the valve, the elastic recoil of the valve will become relatively lesser. And because the elastic recoil will be lesser, therefore the MCQ will say the word soft S1. So whenever you read literature on mitral stenosis, you will read about loud and soft S1, and as you can understand from the data, that soft S1 implies that the examiner wants you to say that this is a calcified mitral stenosis in a patient. The same logic is also valid for patients of tricuspid stenosis. So MS and TS are conditions which are characterized by loud S1 in a patient. In contrast, in some questions where he wants to make it a all except MCQ, he might incorporate data for soft S1, and soft S1 is a feature that is seen in patients with bradycardia. Now, how will the examiner say the word bradycardia? One is obviously that he can use the phrase prolonged PR interval, or instead of talking about prolonged PR interval, he can speak about or mention regarding endocrine conditions like hypothyroidism, which will always be associated with bradycardia. Or conditions of bradycardia can be like disease of the SA node, disease of the AV node, or disease of the bundle of His. Disease of the SA node is called as sick sinus syndrome, where the heart rate of the patient is less than 60 beats per minute. Destruction of the AV node is called as third degree heart block, where the heart rate of the patient will be something to the tune of 40 beats per minute. And if there is a disease or bundle of his, then the heart rate will hardly be 15 to 20 and patient can die. If heart rate is only 15 to 20, that is Mobitz to heart block, the bradycardia will result in soft S1 in the patient. Conditions causing bradycardia are the ones which are enumerated. The examiner can write any of these conditions. He expects you to pick up that the patient is having a decreased heart rate that is less than 60 and therefore bradycardia would cause a soft S1. In some MCQs, however, he might just incorporate terminologies like morbid obesity. You can understand that if a person is very fat and is having lot of fat in the chest wall, then the fat in the chest wall would result in the sound being heard relatively softer. Now, please do not mix it up with muffled heart sounds, because muffled heart sounds is a feature of cardiac tamponade. So here I'm not talking about muffled, but I'm talking about soft S1, because the fat is coming on the chest wall, fat on the chest wall. You see, these people will be having a gynecomastia kind of appearance, very fat chap, with a body mass index of something in excess of 40. So the fat in the chest will result in a soft S1, or another condition can be emphysema. You all know that in emphysema, there is trapping of air in the lungs of the patient, will be responsible for the expansion of the lungs, and the expanded lungs will be covering the heart. And therefore, once the expanded lungs are covering the heart of the patient, the lung tissue is coming in between your stethoscope, which is hearing the sound, because like in obesity, I was saying fat in the chest, here I'm saying air trapped in the lungs is contributing to this. Soft S1 will also be heard in patients having calcified MS and TS, as I explained in the few seconds earlier, where I mentioned regarding decreased elastic recoil. And opposite of MS and TS is MR and TR, that will be having a soft first start sound, because since there's a regurgitation, the coaptation of valve leaflets is not there, and because the coaptation of valve leaflets produces first start sound, in regurgitation the coaptation of leaflets does not occur, so there's a soft S1. I think this is very straightforward, that if you can work out causes of loud, it is very simple for you to work out the causes for soft S1. So that's the only logic that you need to deploy for a loud versus the soft S1, and the examiner or the ploys by the examiner to write these terminologies are the ones which are to be remembered by you. In some questions of first start sound, however, he might actually go a step further by talking about MS in mitral stenosis. You see, in mitral stenosis, what is happening is that this orifice is relatively narrower. Though I've covered this under the murmur section also, you can see that I have deliberately shown a very narrowed valve, and therefore what you can see is that in this narrowed valve, because the opening is relatively smaller, the transit of blood across this narrowed opening would obviously take relatively extra time, because the transit of blood from LA to LV across the narrowed valve will take relatively extra time. The mitral valve of the patient will close relatively later. This is M1, this is T1, so I've just represented them on a two-dimensional scale. Because I'm saying extra time, the mitral valve will close later, and if the mitral valve will close later, therefore the gap between the two will become lesser, and therefore he might say the word narrow split first start sound. In fact, if it does not take treatment, the opening will become even more smaller, and the mitral valve will close even more later, and therefore he might say the word single S1, because both can close at the same time. And in some cases, the mitral valve closure might overshoot the tricuspid valve closure, in which case he might say the word T1M1, and that would be called as a reverse splitting of the first start sound of the patient. For mitral stenosis, today I have taught you 5 findings: loud S1 and soft S1. In the upper part of the slide to talk about traditional mitral stenosis, and then talk about calcified mitral stenosis. At the moment, I've taught you narrow, single, and reverse split S1. So, there are total of 5 findings for first start sound that I've taught you for mitral stenosis. So, in some questions of MS, instead of traditionally talking about the loud and the soft one, he can talk about these splits also. Moving on. In some questions, he will be asking you regarding all our causes of third heart sound except, all our causes of fourth heart sound except. So let's try to run some logic. Third heart sound is also called as ventricular gallop rhythm and is encountered in conditions causing congestive heart failure. Fourth heart sound is due to atrial kick. It is seen in conditions causing a atrial hypertrophy. And atrial hypertrophy can be a feature which is usually encountered in patients with outlet obstructions like valvular aortic stenosis. Third heart sound is heard in the earlier part of the diastole, so it is called as early diastolic sound. Fourth heart sound is called as atrial. It is a atrial gallop rhythm. So because the atrial systole occurs in the later part of the diastole, so this would be called as late diastolic sound. Now, for working out third heart sound, well, third heart sound is seen in conditions having rapid ventricular filling. And fourth heart sound is usually encountered in patients having an outflow tract obstruction. Mind my words there, I did not say inflow, I said outflow tract obstruction is conditions having fourth heart sound. Because outflow tract obstruction, suppose on the left, will cause LVH and will also be associated with LAH, and the left atrial hypertrophy will be responsible for fourth heart sound. I can say a few conditions here that will make it relatively easier for you. The first and the simplest condition that you can understand for fourth heart sound is valvular aortic stenosis. Because it's an outflow tract obstruction, the LV will generate more force and therefore will hypertrophy, and not only will the hypertrophy of the ventricle occur but atria, because sending blood out of the heart is the responsibility of both the ventricles and atria. So aortic stenosis or subvalvular aortic stenosis in the form of hypertrophic obstructive cardiomyopathy are conditions causing a development of fourth heart sound. Let me write down another condition. I might be writing it deliberately wrong also. Hypertension. What do you think? Hypertension should be having a third heart sound or a fourth heart sound? The logic is that hypertension is a condition where peripheral resistance is increased. Hypertension is a pressure-based obstruction, right? It's not a physical obstruction, but it is a pressure-based obstruction. Because a pressure-based obstruction, complication of hypertension is LVH. And also a LAH, and therefore there would be a fourth heart sound that would be heard in hypertension of long-standing duration. If hypertension is a sudden onset, then obviously sudden onset hypertension can result in left ventricular failure. Like during pheochromocytoma surgery, if a patient is having sudden onset hypertension due to sudden release of catecholamines, immediately the left ventricle will fail. But I'm saying long-standing hypertension is a pressure-based obstruction and will result in fourth heart sound developing in a patient. Instead of talking about aortic stenosis, I can mention pulmonic stenosis. In pulmonic stenosis, there would be a right ventricular hypertrophy and a right atrial hypertrophy. The right atrial hypertrophy will generate a fourth heart sound. Or I can write the word pulmonary artery hypertension. In PAH, you see not only the right ventricle but even the right atria can hypertrophy subsequently. So the logic is that for the superior three conditions, it is the left side, that is the left atria, which is working more. So this would be responsible for left-sided S4. Whereas pulmonary stenosis and pulmonary artery hypertension will be responsible for right ventricular and a right atrial hypertrophy, and the right atrial hypertrophy will explain the right-sided fourth heart sound in the patient. Therefore, when it comes to fourth heart sound, it is pretty straightforward. Max to max, they can ask you fourth heart sound is absent in. Then fourth heart sound is absent in patients of atrial fibrillation. Why it is absent in atrial fibrillation is because atria are twitching. Twitching cannot generate power, and it is the power of the left atria or the kick of the left atria that is responsible for fourth heart sound. So twitching implies less power and therefore fourth heart sound would be absent. So absent S4 is a feature of atrial fibrillation, whereas fourth heart sound is a feature of the following conditions. Third heart sound is present in conditions with rapid ventricular filling. The only problem is that how do you know whether a condition is having a rapid ventricular filling? So I would like to put it a simpler shortcut to these questions by saying that whenever you read or you find that a condition is causing dilated ventricles, you see this is just a prop for MCQs, but this works most of the time, that dilated ventricles is gonna be a turbulence in the ventricle, that is the third heart sound present in a patient. Dilated ventricles are found in heart failure. Dilated ventricles are found in dilated cardiomyopathy. Or he might write down respiratory terms like cor pulmonale, or he might say the word acute cor pulmonale. The concept is that both cor pulmonale and acute cor pulmonale result in development of right ventricular failure. And because there's a right ventricular failure developing in a patient, RVF occurring in a patient, the RVF will contribute to third heart sound. In questions, he might deliberately put up cause of cor pulmonale. The number one cause for cor pulmonale is COPD. And the number one cause for acute cor pulmonale is pulmonary embolism. So he might deliberately write down respiratory conditions, making you think. The logic is very simple. In both of these two conditions, there is a right ventricular failure, and this right ventricular failure in the patient is occurring due to a non-cardiogenic cause. The non-cardiogenic causes are COPD for cor pulmonale, which is long-standing, and acute, obviously sudden, that is pulmonary embolism. So right ventricular failure due to non-cardiogenic causes can be squeezed in the question, and already I've taught you about congestive heart failure. Expression by the examiner can be anti-reval MI, it could be beriberi, it could be Coxsackie-B myocarditis, or any other cause of severe anemia for congestive heart failure that he can use. So if you just use the simple prop here, you would be able to work out dilated ventricles versus left atrial hypertrophy for third and fourth heart sound. Simple logics to be worked out, and you'll be able to analyze the data. So mainly I wanted to focus on how to work out aspects for third heart sound, fourth heart sound, and obviously the first heart sound in the previous slide. Now we will be correlating this entire information with that of JVP. So now see how the JVP data fits in here. In part 1 of the discussion, I drew this diagram before you, which I'm drawing once again before you a little faster. Atrial systole. All I'm doing in this diagram is that I am just hypothetically adding, obviously it's not like this, but just for the diagram's sake, this is intrajugular vein, suppose, and that reflects the pressure of the right atria. So when the atria will generate force and will be sending blood into the ventricles, at that particular point of time, this column will slightly move upwards due to pressure transmission. This is passive transmission of pressure that I'm talking about. So in the first diagram, that is atrial systole, I'm showing presence of a positive deflection that is called as the A wave. Now compare this with the second diagram, in which I'm showing isovolumetric contraction with a slight bulge of the mitral and tricuspid valves in upward direction. You can see that no blood is going out of the heart and no blood is coming in the heart, but because the ventricles are in the phase of contraction, they are responsible for slight bulge of the mitral and tricuspid valve upwards, and this upward deflection, albeit a small one that I have shown here before you, will once again affect the jugular vein column. The vector is pointing upward, so this would be responsible for a small positive deflection, that is the C wave. Now compare this C wave, which is seen in IVC, with the next diagram. I will first exaggerate the findings of the second diagram by showing a slightly increased bulge here. This is just an effort to highlight before you what's going to happen subsequently, which is that when the pressure in the left ventricle and the right ventricle will increase significantly, it will cause opening of the aortic and pulmonic valves. Now you can see blood rushing into the aorta, blood rushing into the pulmonary artery of the patient. So both the valves will start coming back to normal position because the ventricles are decompressing, right? So when the blood goes out into aorta and pulmonary artery, the mitral and tricuspid will come back to normal position. The vector is pointing downward, and therefore you can see that this downward deflection of the vector that I have shown here before you is called as the X descent. The basic concept I want you to understand is that in physiology they simply say that X is related to atrial relaxation. I definitely agree to it, but in most of the questions you will notice they will not say the word atrial relaxation, but they will say the word ventricular systole, because obviously when atria are relaxing, ventricles are contracting. You can see the downward deflection of the valves to the normal position will be responsible for X descent, and we will now be comparing this information of a downward deflection of the X with the subsequent wave. So first I'm going to show the mitral and tricuspid valves coming back to normal position. I'm going to show the aortic and pulmonic valves closing. So this is second heart sound now. The diagram is that of IVR. Now follow my blue marker. Don't take notes now. The blood is going to rush into the atria. The blood is going to rush into the atria. It's going to find the valves closed. So this is going to be a result of the blood hitting the valve. The valve is closed. There's no forward possible movement of blood. So the blood hits the column and slightly bounces off. And this is going to affect the jugular venous column once again, and you can see the vector is pointing up, so there would be a V wave in a patient. The V wave is seen in IVR because the mitral and tricuspid valves are closed. If you compare this with the last diagram, you will notice that the positive vector will suddenly turn negative. Let us see the reason for the positive vector turning negative, which is opening snap. In the previous sketch, you saw that mitral and tricuspid valves were closed. But now both of them have opened. So the blood is going to race away into the ventricles. The diagram here shows diastasis. During the phase of diastasis, you can see that mitral and tricuspid valves are opening. So this that I've shown here before you is the opening snap. And you can see that because the vector is going to be pointing downwards. The vector is going to be pointing downwards. This is going to be responsible for the Y descent, which is occurring in the JVP of the patient. You can see that Y descent is related to diastasis. Let's do a quick recap. If you look at these diagrams simultaneously, I want you to compare first the A and the C wave. The difference between the two diagrams is that in A wave, the atrial pressure is being transmitted passively, but once the mitral and tricuspid valves are closed, then the slight bulge of the mitral and the tricuspid valves are responsible for generation of the C wave. So I'll just jot down the theory here that A wave is dependent on atrial systole, as you all know it, no big deal. C is related to IVC, and it is the bulge of the tricuspid valve into the lumen of the LA and RA which is responsible for it. Then you have to focus on the V wave, which is the fourth diagram here. You can see the V wave is due to blood hitting the closed mitral and tricuspid valve. So V wave is found in, as you can see, IVR, isovolumetric relaxation, the fourth diagram on the board. And this is related to the rebound of the blood against the closed tricuspid and the mitral valves. And then there are two negative reflections, X and Y. X is related to ventricular systole, and Y is related to diastasis. So one, you need to remember the sequence here for 3 positive and 2 negative waves. Once you get the diagram right, you need to remember the jugular venous pressure, or JVP, is best checked in internal jugular vein. People who do bodybuilding, they might be having a superficial vein in the neck that is known as external jugular vein, but it is the internal jugular vein in which we check the JVP. The normal pressure of the JVP is 5 to 8 centimeters of water, and we calculate it from the angle of Louis. Angle of Louis would be the manubrium sterni, that is the manubriosternal angle. So JVP, you always are going to check with the patient in a reclining position, and you are going to shine a torch at the base of the neck, and you're going to see some pulsations. Remember that the JVP pulsations are always seen, but they never felt, because what you feel is carotid pulsation. I repeat again, what you feel is carotid pulsation, and what you see is JVP pulsations. The JVP pulsations always occur at 2 times the carotid frequency. The reason why I'm saying 2 times the carotid frequency is because there are 2 big positive and 2 big negative waves. C is anyway, not decipherable, but whatever is the carotid frequency, the JVP pulsations are 2 times the carotid frequency. That means 2 positive and 2 negative deflections. Also remember that when we take a deep breath, on deep inspiration in all of us, the pressure in the chest will turn negative, and negative pressure will suck the blood towards it. I said if I take a deep breath and hold it, negative pressure in my chest is going to suck the blood towards it. So in a normal pressure, in a normal person, JVP falls on inspiration. This is what I said. In a normal person, because when you take a deep breath, the pressure in the chest turns negative, JVP always falls. Now, I'm going to ask a constrictive pericarditis patient. Remember, he was having calcification outside the heart. In a constrictive pericarditis person, when you say, please take a deep breath and hold it there, then the finding in the patient will not be same as you and me, simply because the compliance of the heart is affected. In constrictive pericarditis patient, when he will take a deep breath, even in him the pressure will turn negative and the blood will try to go towards the heart, but heart won't be able to accommodate the blood because there is less compliance, less distentability, ability to accommodate is lesser because of calcification. So in this patient, rather opposite will happen. The JVP will not fall, rather it might exhibit a rise. Let's do this again. In a normal person, when you take a deep breath, the pressure in the chest turns negative. The negative pressure will act like a vacuum, so it will suck blood towards it. As you can see in one of the diagrams, blood is going down. So in you and me, our ventricles are compliant. They can accommodate this blood. But in this chap, constrictive pericarditis person, there is a calcification that will limit the filling of blood. The distentability, the ability to accommodate the blood is limited. So because the heart cannot accommodate the blood, the JVP will not show a fall but will show a rise. This opposite to normal is known as Kussmaul sign. Kussmaul sign is a feature that is encountered in conditions which can be remembered as CRR. CRR would stand for CP is constrictive pericarditis. Calcification is the reason why the compliance or distentability of the heart is reduced. R would stand for restrictive cardiomyopathy. In restrictive cardiomyopathy, there is fibrosis in the myocardium. So due to fibrosis in the heart, the ability to accommodate is lesser. R would stand for right-sided congestive heart failure, which could be either due to inferior wall MI or it could be non-cardiogenic cause of pulmonary embolism, or it could be a non-cardiogenic cause of COPD. Right-sided heart failure, the examiner's expressions are inferior wall MI, pulmonary embolism and COPD, but these are causes which are responsible for presence of Kussmaul sign in a patient. Kussmaul sign is characterized by a rise. Now listen to my next word very carefully. The only medical condition where you have a non-pulsatile JVP. When I say non-pulsatile, it means you can't make out whether it is falling or rising. In you and me, it falls. In this chap, it is rising, but non-pulsatile JVP is a feature of cardiac tamponade. In cardiac tamponade, Kussmaul sign is absent. I repeat that again. The reason why Kussmaul sign is absent is meaning of the word Kussmaul sign is JVP should rise. So you should see the pulsation. That is, it is rising. In cardiac tamponade, you have a non-pulsatile elevated JVP. So therefore, Kussmaul sign is absent in cardiac tamponade. The only two medical conditions where I can just mention it here, the only two medical conditions where you have non-pulsatile JVP is always pulsatile. The only two medical conditions where you have non-pulsatile elevated JVP. Non-pulsatile elevated JVP is a feature that is always encountered in patients who are having cardiac tamponade and superior vena cava thrombosis. In these two conditions, because it is non-pulsatile, you can't make out no rise and fall, so Kussmaul sign is said to be absent in the two conditions. Must know information for today. Non-pulsatile elevated JVP, tamponade SVC thrombosis, and causes of Kussmaul sign CRR, constrictive pericarditis, restrictive cardiomyopathy, and right-sided congestive heart failure. Once you get the basics right, then we can incorporate some more data for JVP here. In today's discussion, I have explained to you the sequence of heart sounds. In fact, I can describe it in a different way that will make it much more interesting for you. Let me correlate this with ECG also. This is P wave. Then is the Q wave for septal activation, QRS complex for ventricular depolarization. Then we have the T wave, and then a U wave that I have not deliberately shown here. The starting of the P wave and the peak of the R wave, the starting of the P and the peak of the R is atrial systole. From peak of the R to the end of the T wave is ventricular systole. Mind my words there. Ventricular systole does not end at the starting of the T, it ends at the end of the T wave. I have shown here is atrial systole, ventricular systole and ventricular diastole. These are themselves questions which have been asked in PGH Chandigarh and are a revision from actually physiology, that atrial systole starts at beginning of P, that's okay, but it does not end at the starting of the Q, it ends at the peak of the R. Peak of the R to the end of the T, surprisingly, not the starting of the T, though we all know T is for repolarization. Ventricular systole ends at the end of T wave, and that is when ventricular diastole. So electrical activity and mechanical activity are two separate ball games. Now you can see that I have shown A wave during the phase of atrial systole, followed by a C wave, and then I am showing the X descent. And I had told you guys that X descent is related to ventricular systole. During the early part of ventricular diastole, there is a positive deflection, that is a V, and then you can see the Y descent happening in the patient. Now this is what I have just said in the previous slide. I said about A, I talked about X, that is ventricular systole, and Y related to diastasis. What I'm doing next in the diagram is that I'm superimposing heart sounds there. The heart sound that I've shown first at the end of the atrial systole is S1, that is first heart sound. And then they can ask you which heart sound corresponds to C to X transition. So I'll just zoom it in so that you can look at this better. You see C is a positive wave and X is a negative wave. So what is causing the positive C to go into X, that is negative? It is ejection click, because movement the aortic and pulmonic valves will open in the phase of ventricular systole. The blood will go out and the positive wave will get converted into negative, that is X, because in X descent, as I showed in the diagram before you, I'll just bring that into focus again. In the X descent, as you can see right now, you can see the aortic and the pulmonic valves opening in the diagram. This is X descent, and you can see the aortic and pulmonic valves opening, so blood is going out and therefore X is happening. So X is the event which is related to ejection click, and that is what I've shown here. Then I have shown endoventricular systole, and endoventricular systole is S2, and if they say which event corresponds to V to Y transition, then V to Y transition, as you can see in the figure, this V to Y transition, as you can see in the figure, is related to a heart sound by the name of opening snap. Opening snap is mitral and tricuspid valve opening. So the moment the valves will open, the positive V will get converted into Y. I'll just bring that to your focus again. You can look at the last diagram that I sketched before you. You can see this is Y, this is a negative descent, and this is directly related to opening of the mitral and the tricuspid valve. That is what I showed and I've represented once again before you. After opening snap, what heart sound do you get? Third heart sound. And which heart sound is present before S1? Remember, I asked you that question in the starting of this discussion. The heart sound which is present right before S1 is fourth heart sound. So if I ask you, doctor, which heart sound corresponds to A wave of the JVP, you should be able to recall this diagram and tell me that fourth heart sound corresponds to A wave of the JVP. C to X transition related to which heart sound? Ejection click. V to Y transition related to which heart sound? Opening snap. I would suggest you to just try and draw this by yourself at least once, so that you are able to solve those very baseline questions of the cardiac cycle that they can mix up with the clinical aspects which I have talked earlier or will be talking subsequently. In this particular diagram, I have tried to link up the ECG with the JVP with the heart sounds of the patient. And just one more concept that I can squeeze in here is like this. If you look at this particular area, that are marked out by yellow, then this particular area that I marked out before you is called as isovolumetric contraction. Isovolumetric contraction, the question can be which heart sound is in the starting of IVC? The answer will be S1. You can look at the diagram and answer. IVC starting S1 and IVC ending is ejection click. Let's do this again. This area that I marked out now before you in yellow, this would be called as IVR, isovolumetric relaxation. So please look at the board and you can answer that IVR, the starting is S2 and the ending is opening snap. The starting is S2 and the ending is opening snap. So for questions which say which heart sound is present at the beginning of IVR, you can tell by logic also. Now all of you know cardiac cycle from first year, so you can tell by logic also. My point is that in the exam, if you try to run too much logic, it can actually, things can go wrong. So this should be an inbuilt reflex for you, that you should be able to mentally relate to this particular diagram that I have made out before you. This is a summary of I would say the correlation of the ECG with the JVP with the heart sounds, and especially these aspects that I mentioned. Fourth heart sound is corresponding to the A wave. The CNX transition is related to ejection click, or VY is related to opening snap. S1, S2 is pretty straightforward. No one would ask you that. And then obviously they can ask you about the starting of IVC and the starting of IVR and the ending of IVC, ending of IVR. So this is known as Wiener diagram. This basically incorporates the three things together. Now, having said that, let's now look at conditions causing presence of a large A wave in the JVP of the patient. You can understand that if there is any stenotic lesion on the right side of the heart, the A wave of the patient will become relatively bigger. So if this is the sketch that I make before you, if I make this opening relatively smaller, then the tricuspid valve of the patient will generate more force to push blood in a forward direction. And you can see in the diagram that because of the fact that this side is having an obstruction, the right atria is generating more force to push blood in a forward direction, and therefore my message is that stenotic lesions of the right side of the heart will cause a large A wave. So I can just mention the names here: tricuspid stenosis and pulmonic stenosis are obstructive lesions in the right side of the heart, and they cause a large A wave. The question is, would you be having a large A wave with a mitral stenosis? Let us see. If patient is having mitral stenosis, you can see the obstruction in the left atria would result in left atrial dilatation. Now I've dilated the left atria of the patient as compared to what it was earlier. I've also shown a congestion in the pulmonary veins of the patient. The congestion in the pulmonary veins will cause congestion in the lungs, that is pulmonary edema. And pulmonary edema, due to back pressure changes, is going to contribute to hypoxia. You see there is fluid in the alveoli, so there would be hypoxia, and hypoxia causes vasoconstriction of the pulmonary bed. So because of the vasoconstriction of the pulmonary bed, there would be a pulmonary artery hypertension in a patient. Now you see that because the patient is having higher pressure in the pulmonary artery, the right ventricle and the right atria both will have to work to push blood in a forward direction, and therefore you can have a large A wave. If you missed it, I'm going to say that again. The back pressure changes in mitral stenosis will explain the fact that in mitral stenosis of long-standing duration, I'm writing the word long-standing just for your relation fact, that in all patients of long-standing mitral stenosis, because there is back pressure changes, the hypoxia that results in vasoconstriction of the pulmonary bed, and therefore pulmonary artery hypertension will ensue. The higher pressure of the pulmonary artery will also explain why in mitral stenosis patients do you have a right ventricular hypertrophy. So mitral stenosis is characterized by dilatation, not hypertrophy, dilatation of the left atria and hypertrophy of the right hand side. The surprising thing is that the disease is on the left, and the hypertrophy is occurring on the right side of the heart of the patient, and the increased pressure in the pulmonary circuit explains the fact that you would have a large A wave, which means the fact that it gives a big leverage to an examiner to incorporate pulmonary artery hypertension. How will the examiner ask pulmonary artery hypertension? He can write down a connective tissue disorder like scleroderma. He can write down drugs that cause pulmonary artery hypertension by the name of fenfluramines. Fenfluramines were weight-losing drugs that were being used by Hollywood and Bollywood celebrities for losing weight for years altogether. They were withdrawn way back in 90s because they used to cause pulmonary artery hypertension. Pulmonary artery hypertension can also be a pediatric information, Eisenmenger syndrome. So most of the time in the exam you will notice the fact that he's not going to ask you TS, PS or MS because that's very understandable. But yeah, the expressions for pulmonary artery hypertension are to be remembered. And then pediatric condition by the name of tetralogy of Fallot can be there. Tetralogy of Fallot is a condition. Tetralogy of Fallot is a condition where the patient will be having a presence of subpulmonic stenosis. And when I say the word subpulmonic stenosis, you have to understand that this subpulmonic stenosis is the one which is going to be responsible for not only cyanosis, but even the obstruction is going to be responsible for a large A wave. or he can incorporate a pediatric condition by the name of Epstein anomaly. I'll speak about this in the congenital heart disease section, but at the moment I want you to remember that Epstein anomaly can also be associated with tricuspid stenosis, and that could result in a large A wave in a patient. From exam perspective, I would like you to specially remember 4, 5, 6 because 1, 2, 3 are very straightforward. Pulmonary artery hypertension, tetralogy of Fallot, and Epstein anomaly are causes for large A wave in a patient. After discussing the MCQ of large A wave, next I'll talk about absent A waves. You see, I told you that A waves are generated due to the power of the atria. A wave is due to atrial systole. If the atria is twitching, in a patient, the twitching cannot generate power. And if the power goes down, the A wave will either become smaller or rather will totally disappear. So in patients having atrial fibrillation, you have an absent A wave. In fact, atrial fibrillation, as I have taught in the earlier part, is the most common arrhythmia in clinical practice. It's overall the most common arrhythmia in clinical practice. For the most common arrhythmia in clinical practice, I'll say like this. In the ECG section, I have taught you that the first wave of the ECG will disappear. P wave is not there because the ectopic foci are the boss. In atrial fibrillation, you can never have a fourth heart sound. Never ever have a fourth heart sound because fourth heart sound is atrial kick, remember. And if atria will twitch, power goes down, atrial kick can't happen. And right now I taught you that in this condition, the first wave of the ECG and the first wave of the JVP are absent. So three things are absent in the most common arrhythmia. That is absent P wave, absent A wave. You can remember like this: first wave of the ECG, first wave of the JVP, and fourth heart sound can never be present in the most common arrhythmia in clinical practice. I have today taught you about large A waves, absent A waves. Now I'm going to talk about super large A waves. The super large A waves are also referred to as giant A waves or are also called as cannon A waves. Where do you have a giant or a cannon A wave? You can have it when atria and ventricles are contracting, maybe simultaneously. You see guys, first atria contracts, then ventricle contracts. But if there is lack of coordination, there's a possibility that two might contract together, and if both will contract together, then the power of atria and ventricle together will cause the column to go much higher. I repeat that again. Atrioventricular dissociation. Atrioventricular dissociation implies that the routine rule does not follow. Traditionally speaking, first atria contracts, then ventricles. You know, that's what I described in the cardiac cycle. First atria 30% filling, then the ventricle contracts. Here, if both will contract together simultaneously, God forbid, then the power of atria and ventricle will be added, and the added power will cause the column to go much higher. Conditions where you have AV dissociation. The conditions to be remembered are VT, ventricular tachycardia. You can go through the arrhythmia section to read about VT, which has AV dissociation, the ectopic foci, or he can mention instead of VT junctional tachycardia, where AV node might be causing activation of both the atria and the ventricles together. AV node becomes the boss. It fires and causes atrial and ventricle contraction to occur together. AV dissociation is also present in a Brady arrhythmia by the name of third degree heart block. Third degree heart block is also called as complete heart block, or is also referred to as Stokes-Adams syndrome. So the terminology here will give a lot of leverage to any examiner to ask data for giant A wave. I repeat again, why do we get a giant A wave? Simultaneous contraction of atria and ventricle. Simultaneous contraction how can occur? There's lack of coordination, and that can be with tachyarrhythmias and bradyarrhythmias both. There are two tachyarrhythmias I want you to remember causing AV dissociation, VT and JT, and the bradyarrhythmias are complete heart block. So there are three MCQs: large, absent, and a giant A wave. The next MCQ that I'll teach you will be for absent X descent. Now let us see how absent X descent will occur in a patient. Please do not take notes and listen to the information carefully. First I'll draw X before you. This is ventricular systole that I'm making before you. The power of the ventricles will be causing atrial blood to rush into the aorta and the pulmonary artery. So mitral and tricuspid valves will start coming back to normal position because you can see blood is going out into aorta and pulmonary artery. So there's a negative vector. This negative vector is responsible for what is called as the X descent, which occurs in a downward direction. Now I will modulate the diagram. This is X ventricular systole. Now I will modulate the diagram by showing tricuspid regurgitation, and I want you to look at it from only mathematics perspective. You can see two vectors, one in color green, one in color blue. Both, one is going down, one is going up. Both will strike and cancel each other. So the question is, absent X descent is encountered in, then tricuspid regurgitation fits the bill because the two vectors will cancel each other. Just to stretch your imagination a little more, I'm going to make this more stronger. I'm going to make it a severe tricuspid regurgitation. So I'm going to show a very large amount of blood literally obliterated. You can see in the diagram that there is so much of blood going backward that this blood will literally obliterate the X descent of the patient, and therefore you can see in the figure that the patient is having a severe variety of TR, and now the vector will not be negative, rather it might turn positive also. This is what I'm saying. Please follow. This is normal JVP recording A, then you have a C, then you have a X, V and Y. This is how the normal tracing is for us. In this patient that is currently on the board, there is a normal A like this, then there's gonna be C, but then there's no X. I have deliberately obliterated the X because X is a downward vector, it's not there. And then in this patient, the lift off will occur from here only. This is the representation of the JVP of a person who is having a presence of a severe TR. You can first focus on this particular area where I put a single star mark. This area where I put a single star mark is called a CV wave. I'm calling it a CV wave simply because the positive deflection, there's no X, the positive deflection, after C there's a positive, so CV wave. And then this area where I put a double star mark, this looks like a downswing of a roller coaster ride. The downswing of the roller coaster ride is called as steep Y descent. So steep Y descent is a feature. Steep Y descent is a feature that is encountered in patients of severe variety of tricuspid regurgitation. As you can see, laws of gravity, man, anything goes up has to come down. I have taught you 3 MCQs with respect to tricuspid regurgitation: absent X, CV wave, and a steep Y descent. This particular diagrammatic representation gives you an insight into why do you have an absent X, and then you have is a CV wave and a steep Y descent. After discussing the MCQ of absent X descent, I'm going to talk about a condition having an absent Y descent. Y descent is related to diastasis, that is free filling of blood in the ventricles of the patient. I've drawn the diagram of diastasis at least twice in this discussion. When I say the word absent Y descent would be present in a condition where the heart cannot relax. Now look at the surprising thing that I'm saying. Heart can contract but is not relaxing. How is that possible? That is possible if you are having a substantial amount of fluid outside the heart, which is gonna put pressure, and this pressure is gonna prevent the complete relaxation of the heart. The condition that I'm showing before you is called as cardiac tamponade. If you look at the red arrows here, you can see that they are pressing on the heart from outside. So if you just go by vector, the heart can still contract, but relaxation is not possible. You see, cardiac tamponade is a condition where there is less filling of blood in the heart. In cardiac tamponade, there is intrapericardial space pressure. The area where I put the red arrows, intrapericardial pressure is higher than the filling pressure of the left ventricle. If the filling of the left ventricle will be lesser, less will come in, less will go out, and therefore in these patients, the BP will begin to fall. As more fluid will accumulate, the BP will begin to fall. This kind of a shock that develops if the filling of the ventricles is compromised is called as obstructive shock. Don't call this particular discussion as an example of cardiogenic shock, because it is not the ischemia of the myocardium, it is the filling that is compromised from external cause, that is the intrapericardial space pressure. The area where the red arrows are there, the intrapericardial space pressure is more than the filling pressure of the left ventricle. This medical condition that I am teaching you right now is called as cardiac tamponade. The concept to be understood is that in tamponade, heart can contract, but relaxation part is compromised. and therefore there is a hemodynamic compromise. And if you want to increase the BP of this patient, it's not IV fluids or not vasopressor. If you remove the fluid via pericardiocentesis, only then the pulse will stabilize, BP will stabilize, and the Y wave, the JVP will come back. Why the Y wave or JVP is absent is because I said no heart can contract but can't relax absent diastasis or decreased diastasis. So Y will be either reduced in slope or would be absent. Cardiac tamponade is characterized by absent Y descent in a patient. In fact, most of the MCQs of cardiac tamponade will mention regarding the following findings. In fact, I can use a different slide to mention the important findings of tamponade that you should be aware of. Most of the time they ask about pulse, BP, heart sounds, and JVP findings for these patients. In cardiac tamponade, for the pulse part, remember there is pulsus paradoxus. Meaning of the word pulsus paradoxus will be that the pulse will tend to disappear in the phase of inspiration, not expiration, inspiration. The blood pressure of the patient will become unrecordable. The heart sounds of the patient will become muffled. In the JVP, the Y descent will be absent. Since I'm saying Y descent is absent, this would be a non-pulsatile. It's not gonna fall, it's gonna remain elevated only. So it's gonna be a non-pulsatile elevated JVP. When I say descent is absent, it means it's not gonna fall. And if it's not gonna fall, it's gonna be a non-pulsatile elevated JVP. The pulsations are gonna disappear in the patient. The pulsations of the JVP won't be seen. In normal person, the JVP falls, but in this patient, it would always remain elevated. In fact, you can understand the condition that I explained to you once again in a slightly different fashion. Have a look at this. In the earlier part of the discussion, I have taught you the fact that during inspiration, more blood comes in the right side of the heart. We've discussed that a couple of times. Inspiration, more blood coming in. Because more blood comes in, it will require more space, so it will cause a slight septal deviation. Because of this septal deviation, the cavity of the left ventricle in yours and mine will be smaller. If you take a deep breath, more blood comes in the right side of the heart. If more blood will come in, it will take some space, will cause a septal deviation. So LV cavity size will become smaller. If LV cavity size will become smaller, end diastolic volume will be lesser, stroke volume will be lesser, and therefore the BP and the cardiac output will also be lesser. So you can see that our blood pressure tends to fall in the phase of inspiration. You can see in the figure that during inspiration, because there is a septal deviation, the BP tends to fall. Compare this with the next diagram that is in the phase of expiration. During the phase of expiration, you can see that relatively less blood is going to come in. So I have shown the septum which was deviated coming back to normal position. And if the septum will come back to normal position, therefore in this patient, if the left cavity size is of normal size, then you can see that the BP will tend to recover or will tend to become normalized. You can see the fact that during the phase of inspiration and expiration in you and me, the BP value is not constant but it varies. Let me say if the expiratory value of your blood pressure at the moment is 115 millimeter of mercury, then the inspiratory value of yours will be something like, let me say, 110 millimeter of mercury. If a blood pressure of a normal person is recorded in inspiration, it will be lower as compared to that of expiration. This difference of inspiratory and expiratory blood pressure for you and me is less than 10 millimeters of mercury. Now, if you're gonna be having fluid outside the heart, this fluid, though it's a two-dimensional diagram, still should do the trick. In this particular case, if there is fluid outside the heart, this fluid is gonna cause an exaggerated septal deviation. You can see I've shown an exaggerated septal deviation. The exaggerated septal deviation will cause a further reduction in the cavity size of the left ventricle, causing a further reduction in end diastolic volume, further decrease in systolic blood pressure, and therefore because the systolic blood pressure will fall more than normal, therefore if the difference between the systolic blood pressure in inspiration and expiration is more than 12 millimeters of mercury, we tend to call it pulsus paradoxus. What I've just shown here before you is referred in the textbook as reverse Barheim effect. What I mean by reverse Barheim effect is simply the fact that the pressure which is present is going to cause an exaggerated septal deviation. So there's going to be a further reduction in the cavity size, and therefore the blood pressure is going to reduce much more than 10 millimeter. This difference of more than 12 millimeter in the systolic blood pressure during inspiration is the one that is technically called as pulsus paradoxus. The paradox is that the pulse is beginning to disappear though the heart is beating. You see, I am not teaching you cardiac arrest. Had I been teaching you cardiac arrest and said pulse is disappearing, agreed man. In this case, there is no disruption of cardiac activity. Heart is still beating. It can still contract. It's not able to relax though. And therefore, there's a difference of more than 12 millimeter systolic blood pressure. During inspiration, we call it pulsus paradoxus. This is a finding that we encounter in patients of cardiac tamponade. And this finding will rather highlight the fact that why cardiac tamponade is a life-threatening condition, or is called as an example of obstructive shock, because the filling of the ventricle is getting, the left ventricular filling is getting compromised. If we evaluate the data that I have said here for the JVP, the important findings for JVP to be remembered are like this. There are questions on the A wave, that could be for large A wave, absent A wave, and super large A waves. Large A waves is stenotic lesions of the right side of the heart, including pulmonary artery hypertension, that I want you to remember. Then could be like subpulmonic stenosis. Absent could be the most common arrhythmia, atrial fibrillation. Canon A wave for tachyarrhythmias is VT and JT. Junctional tachycardia would be having AV node becoming the boss, causing retrograde firing of atrial ventricles together. Or it could be third degree heart block or AV dissociation. Then we spoke about absent X, that is tricuspid regurgitation. CV wave and steep X were also discussed with respect to tricuspid regurgitation. Then I've talked about absent Y. Absent Y is a condition where heart is not in a position to have a relaxation, that is cardiac tamponade. In some questions, he might use the phrase steep X and absent Y. I just want you to focus on the word absent Y, and steep X is a feature of cardiac tamponade. Cardiac tamponade mainly affects the filling of the ventricles. It's obviously going to affect the filling of the atria also, but the septal deviation that I'm talking about, that is mainly pronounced in the ventricles. So that's why we're talking about absent Y descent in a patient. Along with this, they can ask you regarding co-small sign. Co-small sign is a feature of CRR, constrictive pericarditis, restrictive cardiomyopathy, and right ventricular failure. For right ventricular failure, I mentioned a couple of props, but these are some of quick revision for JVP that I want you to remember, the various waves and the important questions which are to be remembered for this particular part of the discussion.